Welcome everyone. We're at the Ovarian Cancer National Conference in Seattle run by the OCRA, and I'm Jane Ludeman from Cure Our Ovarian Cancer, and I'm joined by Kristen Larson, another low-grade serous ovarian cancer patient. We're very honoured to have Dr Gershenson from MD Anderson joining us today. Dr Gershenson is widely recognised as the world-leading expert on low-grade serous ovarian cancer, so we're honoured to have him here today. So this is our Part 2 series on low-grade serous ovarian cancer, speaking about research today. So Dr Gershenson, I know your research lab at MD Anderson has really been at the forefront of low-grade serous ovarian cancer research, and you've been involved in a lot of studies. I was wondering if you could tell us a bit about the research that you've already done on low-grade serous ovarian cancer.
Thank you, Jane. It's great to be here. So right now there are 3 areas of investigation that we're focusing on in the preclinical arena. One of them is immunotherapy, and again my colleague Dr. K.K. Wong has identified a protein which is an immunotherapy regulatory protein called B7H4 that is overexpressed in serous carcinomas of the ovary, both high-grade serous and low-grade serous, and he has received a Department of Defense grant to study this further. In conjunction with this, there's a phase 1 trial at MD Anderson with an antibody specifically against B7H4, and there has been one ovarian cancer patient that has responded to this antibody and had a partial response for a period of almost a year. And so we're very interested in pursuing this strategy, possibly using this drug either as a single agent or in combination for patients who have low-grade serous carcinoma. So that's one area of investigation that's of great interest. A second area is the area of genomics and genetics. So we have recently completed a trial, which is GOG 281, which was a phase 3 randomized trial of a MEK inhibitor, trametinib, versus a standard of care. And in this trial, we had performed pre-treatment biopsies on all patients. They also had submitted archival formalin-fixed tissue to us for the trial. We recently received approval from the National Cancer Institute to study these tissues in collaboration with our partner Charlie Gurley, who's based in Edinburgh in the UK. And we are going to be sequencing all of these tumors from the patients on the trial using whole exome sequencing, and hopefully we'll be able to finally answer the question of whether or not we can correlate response to trametinib with whether a patient has a mutation within the MAP kinase pathway. We're also going to be measuring phospho-ERK because we have preliminary evidence from our first trial with selumetinib that women whose tumors had higher levels of phospho-ERK tended to respond better to the MEK inhibitor. So those trials are ongoing. In addition to that, in terms of preclinical investigations in the genomic area, Dr. Wong has found that about 25% of low-grade serous carcinomas have a partial loss of chromosome 9. On chromosome 9 is a gene called P16, and we know that women whose tumors have loss of P16 may have better responsiveness to a drug called a CDK4/6 inhibitor. So we are considering in the future a combination trial with the CDK4/6 inhibitor combined with a MEK inhibitor in the next trial or so based on that preclinical work. In addition, in that area of genomics, we have profiled 14 women's tumors with whole genome sequencing, which is a much deeper dive into the genome of the tumor. And we found some genes that have not been previously described, some gene mutations. And Dr. Wong is currently preparing a manuscript to report that information, so that will be interesting as well. And the final area of preclinical investigation is endocrine signaling. We have found that the estrogen receptor in low-grade serous carcinoma may in many instances be very different from the one we see in ER-positive breast cancer and have a very different configuration. And we want to know if that somehow translates into the responsiveness of low-grade serous carcinoma to various hormonal medications. We may be able to find that if a woman's tumor has a certain configuration of the estrogen receptor, the tumor may be more susceptible to one hormone, whereas another configuration may be susceptible to another. And that's really the bulk of our preclinical work right now. We also have a number of clinical trials. As I mentioned, we've completed the GOG 281 trial. The clinical information from that is being finalized, and we hope to present that at the upcoming meeting of the European Society of Medical Oncology, which will be held in Barcelona in late September. The other trials that either have been launched recently or will be in the next month or so are the frontline trial for women who have stage 2, 3, and 4 low-grade serous carcinoma, who will, after primary cytoreductive surgery, be randomized to either chemotherapy followed by letrozole maintenance or to letrozole monotherapy. And that trial is potentially practice-changing if we find that one of these strategies is superior to the other. The other two trials involve CDK4/6 inhibitors. The one trial is for women who have recurrent low-grade serous carcinoma, combining letrozole with a ribociclib, which is a CDK4/6 inhibitor, based on the results that have been demonstrated in ER-positive breast cancer. We hope we will see an improvement over letrozole alone indirectly, and then can maybe move on to a randomized trial. The other trial involving a CDK4/6 inhibitor was going to be given in a pilot study with an anti-estrogen injectable hormone called fulvestrant. And this trial is for women who will be having neoadjuvant treatment based on the fact that they present with very extensive disease and would otherwise have received neoadjuvant chemotherapy. So instead, they'll be receiving, on this trial, neoadjuvant hormonal therapy, and this will give us much better information about the susceptibility of low-grade serous carcinoma to a hormonal agent plus a CDK4/6 inhibitor.
And can you tell me a little bit more about what areas of research are yet to be fully explored that you think could lead to survival improvements for women? I'm thinking in terms of drug combinations, immunotherapy.
It's mainly going to be in the area of combinations. And I think we know bevacizumab's active, we know hormonal agents are active, and we know MEK inhibitors are active. We don't know exactly how active, but we'll know that from the results of our trial that will be reported later this year. So the next step, I think, in the long-term strategy is to begin to combine these agents. And that will be somewhat empirical, but it will be combining MEK inhibitors with CDK4/6 inhibitors, with bevacizumab, with letrozole, or combining letrozole with bevacizumab, et cetera, et cetera. So that's, I think, going to be the focus over the next 5 to 10 years. It will be combination therapies.
Wonderful. Thank you so much for your time. Just one last question while we have you here. What made you interested in low-grade serous ovarian cancer and to choose that as your area to study?
Great question. I'm not sure I have a great answer. So I was interested back in even as early as the 1980s in serous borderline tumors, when I first started my training at MD Anderson, the senior pathologist there did not believe that borderline tumors actually existed. He thought that they were all really invasive cancers and there was no such thing as a borderline tumor. And he would always say, they're not really any borderline tumors, they're only borderline pathologists, which was a little bit humorous at the time. But what happened with that is it resulted in over-treatment of many, many women with multiple surgeries, multiple chemotherapy regimens for borderline tumors, and that was unnecessary. Once Dr. Elvio Silva came to our institution, again as a trainee about the same time as I did, we developed a joint interest in borderline tumors, and during the 80s and 90s began to study them, and we were most interested in those borderline tumors where they were associated with the peritoneal implants, because we recognized that that had a different prognosis than if it was limited or confined to the ovary. And from that, we then found that these women who had borderline tumors as well as peritoneal implants on some occasion would subsequently develop these invasive cancers. And even some of the world's experts at the time, and this was back in the 90s mainly, but even as recently as 2000, were very skeptical that you could have a diagnosis of a borderline tumor and then later on have low-grade serous carcinoma. So we were able to demonstrate that, I think, very convincingly with a series of studies. And then that just led to the development of the two-tier grading system, where we wanted to really focus in on serous carcinoma and not be left with this amorphous three-tier grading system that we had for many, many years. And then that just led to the clinical studies, the observational studies, and then on to the clinical trials. So it was a kind of a progression of interest from borderline tumors on to invasive low-grade serous.
Well, we're definitely really, really grateful for all the work you've done for our community, and thank you so much for your time here.
Thank you very much. I appreciate it, Jane. Thank you. You're doing great work.